Good morning, everyone. So, today we will be discussing about neurocognitive disorders, which comes under the psychiatric and mental health. So, as I mentioned before, we will be discussing about neurocognitive disorders. So, let's move on to the presentation without wasting in further time. Right. So, neurocognitive disorders. So, cognitive disorders. What are the cognitive disorders? Cognitive disorders, they do affect memory, orientation, attention, and judgment due to primary or secondary abnormalities of central nervous system. Neurocognitive diseases develop mostly in later stages of life. Cognitive patients may suffer with psychiatric symptoms like depression, anxiety, paranoia, hallucination, and delusions. Delirium, dementia, and amnestic disorder are some of the major cognitive disorders. Right. Now, what is this? Cognitive disorders, they mainly affect what? They mainly affect the diseases which affect memory due to the primary or secondary abnormalities of the central nervous system. That means what? They mainly affect memory, orientation, and attention, like the normal altered level that causes altered level of consciousness due to due to a damage that directly causes to the central nervous system, or due to a damage that secondarily causes to the central nervous system. Sometimes it might cause one thing, and that secondarily may damage the central nervous system, not the direct effect. Okay, so due to primary or secondary abnormality which causes in central nervous system, if this memory impairment, orientation, and if the altered level of consciousness happening due to that, we call that condition a cognitive disorder. So basically, the central nervous system damages happens in later in our lives. So mostly that develops in later stages of life. So they may suffer with psychiatric symptoms like depression, anxiety, as said here, and these disorders include dementia, amnesia, delirium, and some other diseases. Right. So here we have a diagram which shows how the neurodegenerative or neurocognitive disorders occur. Basically, you can see some kind of a stress here, oxidative stress, heavy metal and pesticides, or any other defective protein aggregation or protein degradation. Such things damages this neuron, yes, and that leads to neuronal loss or damage in the neuron. So eventually that leads to neurodegenerative disease. Right. Now, neurocognitive disorders, or the main topic of the presentation, we have a few types of disorders to discuss. What are those? First, that's delirium, then neurocognitive disorder due to Lewy bodies, then disorders due to Alzheimer's disease, then frontotemporal neurocognitive disorder, then vascular neurocognitive disorder, and disorder due to traumatic brain injury. Right, so let's move on. First disorder we have to discuss is delirium. Actually, that's a state of we can say a confused state. Yes, delirium is a neuropsychiatric syndrome, also known as acute confusional state. Yes, as I mentioned before, that's a confusional state. Patient is not he is getting confused, he or she, and not coping or not very well oriented to the place, person, and time. And it's temporary mental state which may cause confusion, anxiety, incoherent speech, and hallucinations. Delirium may cause change in cognition like memory deficit or deficiency, then disorientation and language disturbance. Males are at higher risk of suffer with delirium. Yes, males at a higher risk. Then toxins, surgery, head injury, shock or infections in brain by bacteria, viral may be the major cause of the disease. Right. Now here, pay attention. This delirium, that's a confusional state which develops over a very short period of time. Okay, very short period of time. Not a it doesn't. That's an acute condition, and patient may be suffering with hallucinations and may be confused, or speech and language disturbances are there, right? So signs and symptoms of delirium: speech problems, yes, motor problems. Either patient might be hyperactive or hypoactive. Then sleep disturbances, hallucinations, language disorder, perceptual disturbance, reduced awareness of environment, yes, we say confused state. Then cognitive impairment, right, like poor thinking skills, emotional disturbances and behavioral changes. Yes, after all these symptoms, of course, patient will be having behavioral changes. Signs and symptoms of delirium usually begin over a few hours or few days. Yes, we mentioned that it's an acute condition. They often fluctuate throughout the day, and there may be periods of no symptoms. And this tend to be worse at night. Now, these symptoms, they fluctuate throughout the day and reaches peak at night. Okay, that becomes worse at night when it's dark, especially, and when the things look less familiar. Okay, right. The types of delirium. First type is hyperactive or hyper alert delirium. The patient is becoming hyperactive. With hyperactiveness, yes, aggression is there. He is aggressive. He argumentative. Argumentative as in he argues with healthcare professionals, his family, yes, everything, and uncooperative. Patient is not cooperative at all, because his thinking pattern or his level of consciousness is different from a normal person. May appear to be responding to internal stimuli. Yes, sometimes his what do you call the behaviors, outside person, for an outside person, that might be very hard to understand this person's behavior with delirium, right? Frequently the people suffering come to our attention because they are difficult to care for. What is this? Basically, when people who are suffering from delirium, when they become very hard to cooperate, or when they become very difficult to take care of, then these people, they come into attention of the mental health or psychiatric healthcare personnel, right? Then the next type is hypoactive or hypoalert delirium. This is something which goes hidden. Normally we miss these kind of patients because they are not problematic. What's happening here? Persons appears to be napping on and off throughout the day. Yes, they seem to be lethargic, right? Fully lethargic, no harm to anyone. They are in their own world, unable to sustain attention when awake, quickly falling back asleep. Misses meals, medications, and appointments. Of course, they miss their meals. They don't care about that. Does not ask for care or attention. Yes, they are in their own world. This type is easy to miss because caring for this patient is not problematic to staff. Yes, staff or family members, they don't have any problem in caring such kind of patients. They most of the time they look lethargic and they sleep all the time. Sorry. Then we have another type. Together these two types, mixed delirium. What is this? This includes both hyperactive and hypoactive symptoms. The person may quickly switch back and forth from hyperactive to hypoactive states. Patient is becoming hyperactive and again hypoactive. He will become aggressive, argumentative, and the patient becomes very hard to handle, not cooperative at all. Then again he starts to sleep like that. The most common types are hypoactive and mixed, accounting for approximately 80% of delirium cases. Hyperactive cases are around 20%. Together, mixed and hypoactive accounts for 80% of cases. So, what are the types of delirium? Again, hyperactive, hypoactive, and mixed. Hyperactive, uncooperative, aggressive, argumentative. Hyperactive, lethargic, sleeping all the time, and mixed, switching between these two types. Causes of delirium. First of all, what you should know, the causes are completely not understood. Okay, causes for delirium are not completely understood or stated, but basically we think that delirium occurs when the normal sending and receiving of signals in the brain become impaired. Okay, when the signals, when there's a signal impairment, we think that causes delirium basically. This impairment is most likely caused by a combination of factors that make the brain vulnerable and trigger malfunction in brain activity. Yes, delirium may have a single cause or more than one cause, such as medical condition and medication toxicity. Sometimes no cause can be identified. Yes, basically we think the signal impairment. Now the complete causes are unknown, but we think signal impairment causes that. For signal impairment, what are the causes? That may be a single cause or many causes, like medication toxicity and other medical conditions. Causes of delirium they have identified 5 main leading causes, especially by a study done with elderly patient by Francis and colleagues. What are these main 5 causes? Fluid or electrolyte disturbance or imbalance, in infection, yes, after like post-infection, during post-infection period, that may cause brain damage, which impairs signals. Then medication toxicity, like toxic medicines. Then metabolic derangement. Then sensory and environmental disturbance. Right. Then the next disease we're gonna discuss is dementia. As soon we say dementia, which comes to your mind? Yes, memory loss or loss of memory. Right, we'll see what is dementia. The term dementia is derived from the Latin word demens, or private, means mind, intelligence or judgment. Okay, let's keep that apart. It causes long-term loss of ability to think and represent decline from a previous level of functioning. This is more common in females. Now delirium was common in males, now dementia is more common in females. May be caused by Alzheimer's disease, HIV, head trauma, Parkinson's disease, Pick's disease and Huntington's disease. Right, what's happening here? That's a long term here. It causes a long term loss of ability to think. So that's a long term process which causes gradual loss of memory. Don't say memory loss when you see the word dementia. Right, so let's move on. Signs and symptoms of dementia. What are those? First of all, agitation, then depression, then the tremors. Patient will be having unintentional tremors, then balance problems, speech and language difficulty, hallucinations, anxiety and restlessness. Now here, one thing you can understand with these neurocognitive disorders or neurological related psychiatric disorders, we mentioned at the very beginning that these things occurs in late stages of our life. Yes, in later stages. Now here we don't have what we should remember is, yes, the thing doesn't cause dementia alone, that causes some other symptoms as well, like agitation, depression, tremor, balance problems. So all these things looks like maybe Parkinson's disease due to Alzheimer's disease, maybe due to Huntington's disease. So as a cluster or in a group, these symptoms and signs, they look same alike. Right. So dementia versus delirium. Dementia, now you might be confused between these two words. Dementia has an insidious onset, chronic memory and executive function disturbance, tends not to fluctuate. Now here dementia. And dementia has intact alertness and attention but improvised speech and thinking. Now dementia, that's a long term or insidious or gradual onset with a chronic memory impairment, and this doesn't fluctuate. But delirium, cognitive changes develop acutely and they fluctuate, and speech can be confused or disorganized, alertness and attention wax and wane. Right, in delirium what happens? We said those symptoms, they fluctuate and reach peak at night time. Yes, especially at night when the things are not clear. And now for a normal naked eye also things are not clear at night. So in case of delirium, that becomes obvious. These symptoms, they fluctuate. But dementia, that's a gradual onset and the disease is developing, doesn't fluctuate. In delirium, that that's an acute condition which develop within hours or days, and that fluctuates, right? Treatments. What are the treatments for this condition? First and foremost, treat the underlying cause. Of course, if there's now for an example, if there's a medication toxicity, stop the medication, or we have to stop that toxicity. Environmental interventions. Cues for orientation must be used, like calendar, clock, family pictures, windows, to make sure that he is oriented to time, place, and person. Right. Frequently reorient the patient. Yes. Now we have to keep on remembering, and the therapeutic aspects we will discuss these things once we meet each other in class. Then have family or friends visit frequently, making sure they introduce themselves. Like most of these patients who are suffering from dementia, they are not able to identify their family members even at times. So when they come, we have to keep on reminding them, or we have to reorient. We have to keep on reorienting the patient. Minimize staff switching. Yes, it's better if we can keep the same staff for these kind of patients, right? Then we have another disease to discuss, that is neurocognitive disorders, disorder due to Lewy bodies. What are the Lewy bodies? Or Lewy bodies, you can say, microscopic protein deposits that damage brain over time. Now, these protein deposits, those are microscopic. Okay, we cannot see from naked eye, and they deposit and they damage brain over time. These kind of condition we call neurocognitive disorder due to Lewy bodies, right? NCDLB, or neurocognitive disorder due to Lewy bodies, is the newest dementia diagnosis with an incidence of 7 per 1000. So it's a new aspect or new area of dementia which is diagnosed with 7 per 1000 individuals who are 65 years and older. Individuals with NCDLB are often misdiagnosed with NCD. What is NCD? Neurocognitive dementia due to Parkinson's disease. Both show similar motor and cognitive clinical symptoms. Now, NCD and NCDLB, like neurocognitive dementia and neurocognitive dementia due to Lewy bodies, they basically show similar motor and cognitive clinical symptoms, and we misdiagnose that with Parkinson's disease. So, as I mentioned before, these all things have a similar the signs and symptoms, they look alike. Like these are intense neurotransmitter deficits along the dopaminergic and cholinergic pathways. Now, what are the neurotransmitters? These are intense neurotransmitter deficits along the dopaminergic and cholinergic pathways. As you know, in our nervous system, neurons at the end of the neuron, or in the end of the axon, we have axonal bulbs, and from this to the next neuron, the gap, we call that the synapse. And for signals to transfer, when a signal comes, there must be a neurotransmitter. So if the neurotransmitter is acetylcholine, we call that synapse a cholinergic synapse, or that pathway a cholinergic pathway. So if the neurotransmitter is dopamine, we call that dopaminergic synapse, or a dopaminergic pathway. Now, for an example, if we are waiting at one bank of the river to go to the other side, what do we need? We need a boat. Yes, and just imagine the river is the synapse, and we need a boat to go to the other side. This is somewhat different from the actual scenario, but still, or else we can swim to the other side, but we need boat at least, right? If there's nothing in between, let's imagine there's a big what do you call? There's a big gap. So let's imagine there's a river, we want to go to the other side, and we need a boat. So just imagine that boat is the neurotransmitter, and if the boat, now we have seen many, there are boats with different names, or there are ships like Titanic, the Britannic, and the Carpathian, like that. So if the ship or the boat's name is dopamine, we call that pathway a dopaminergic pathway. Or if it's acetylcholine, the ship is acetylcholine, we call that a cholinergic pathway, right? So due to this neurotransmitter deficit, right? In the cholinergic deficit, acetylcholine is responsible, whereas the dopamine responsible for motor dysfunction, right? NCDLB or neurocognitive dementia due to Lewy bodies can be differentiated from NCD due to Parkinson's disease based on the chronological onset of symptoms, right? What is chronological onset? The time of onset of the symptoms. Individual with NCDLB will exhibit cognitive symptoms before the onset of motor symptoms, right? Their cognition, the cognitive behaviors, they deteriorate before the motor symptoms. Motor symptoms, they deteriorate, especially in like cases of like Parkinson's syndrome and NCDs, right? This results in a collection of proteins called Lewy bodies that progress through the neuronal synapses. We mentioned that microscopic protein deficits or deposits, they damage the brain tissue. The functional deficits seen in, with NCDLB are greater than NCD with Alzheimer's disease as a result of the effect on motor and involuntary nervous system, right? Treatment for this condition is, when developing a plan for individuals with NCDLB or dementia due to Lewy bodies, it is important to modify care by having the patient or caregiver rank the cognitive, emotional and motor difficulties by level of subjective distress. Now, what is this? It's important to rank the level of difficulty. And the medications are effective with many symptoms, including fluctuating cognition, hallucination and mood disorders. Then the next condition is neurocognitive disorder caused by Alzheimer's disease or NCD due to AD. That's a slow developing non-reversible brain disorder that results in permanent loss of neurons and neuronal synapses. Now here, neurocognitive disorder due to Alzheimer's disease, there is a slow developing non-reversible brain disorder that results in permanent loss. Okay, pay attention. Slow developing and non-reversible. Now these things are chronic. That means the loss of neurons is prevalent in the area of the brain responsible for memory, function and cognition. Now we said permanent loss of neurons and neuronal synapses happen, and that is prevalent, or that is very much prone in areas which are responsible for memory, function and cognition. Neuronal destruction comes from extracellular neurotic plaque and neurofibrillary tangles inside neurons. Acetylcholine, which enables learning and memory, is also decreased. That means which pathway? The cholinergic pathways. Risk factors for NCD due to AD is gender neutral. That means occurrence is equal in males and females. Now delirium, we said that's common in males, dementia common in females, but this condition, that's common in both, equal in both males and females. Family history and age increase the risk of developing NCD due to Alzheimer's disease if the family history is there, and increase age. That works as a risk factor. The risk for an individual with a parent or sibling with NCD due to AD increases as much as 30% with each affected family member. Now let's say we are having someone in our family who is suffering from this condition, maybe a parent or maybe a sibling. Then that means we have a 30% of increased chance of getting this disease, right? Treatments are pharmacological treatments for this condition include cholinesterase inhibitors and methyl aspartic acid receptor antagonists. We will discuss about the mechanism of action. That's not in this scope, but cholinesterase inhibitors, you can imagine they inhibit this cholinesterase, yes, and methyl aspartic acid receptor antagonists. Just remember the two classes of drugs, pharmacological treatments, right? Although cholinesterase inhibitors do not stop the disease trajectory, they may slow the decline. Now, what's happening? We said that is a non-reversible case, a long-term non-reversible destruction. Now, what's happening here? They may do not stop the disease, but they slow the decline. Right. Then there's another condition we have discussed, frontotemporal neurocognitive disorder. That's a mental health condition characterized by abnormal shrinkage in two parts of the brain. Now, what are the two parts? Yes, you can get from the name of the disease itself. The frontal part, the frontal lobe, and the temporal lobe, especially the anterior frontal and temporal lobes. Here, shrinkage in two parts of brain called the frontal and temporal anterior lobes. This condition replaces an essentially equivalent illness known as frontotemporal dementia in DSM-5. What is this? This condition replaces an essential equivalent illness which looks similar, known as frontotemporal dementia. We call that frontotemporal neurocognitive disorder in DSM-5. What is that? It's like the Bible of the psychiatric disorders, the diagnostic and statistical manual of mental disorders, the 5th edition. Right. The brain's frontal and temporal lobes play a primary role in maintaining brain function, such as the ability to use language, ability to regulate behavior. Yes, frontal and temporal bones are responsible for that. That's why sometimes people, they say that people who are having a big frontal bone are clever and have a good IQ, because the language command and frontal lobe accounts for such things in our body. The specific manifestation of the disorder depends upon the particular portions of the frontal and temporal lobes that undergo shrinkage, as well as the degree of shrinkage that occurs at a given point of time. The manifestation depends upon the portion. Yes, which portion is deteriorated, so the manifestation of the symptoms will be depending upon the portion and which part undergoes shrinkage. Basically, which part affects, then that part will give the signs and symptoms. Signs and symptoms are loss of normal ability to make appropriate decisions or control impulsive urges, like the patients, they will lose the ability to make appropriate decisions. Loss of ability to show empathy with others or develop personal motivation. Changes in self-grooming or eating habits. Yes, this is very much obvious, because self-grooming and eating habits will be different or will be impaired in this condition. That is one of but that helps us in diagnosing this condition as well. When if a normal eating habit, we know if a person eats in a different way, if the eating habit is very disorganized or disoriented, we can suspect this kind of a condition there, right? Then other symptoms are language or speaking related difficulties associated with this disorder. Yes, we said the frontal bone or frontal lobe of the brain getting affected. Disorder, this language problem includes aphasia. What is aphasia? Loss of ability to use or understand words. Sometimes we may feel like the patient is just blabbering and he is not understanding what we say. Yes, so that's normal in this condition. The frontal lobe, when get damaged, aphasia could happen. Loss of ability to use or understand words, and difficulties with normal body movements such as rigid or trembling muscles. Loss of ability to coordinate the activity of different muscles, like very small things, or the fine motor skills. Then unusually weak muscles or swallowing problems. Treatment are both frontotemporal neurocognitive disorder is both incurable and progressive, gets worse over time. So the treatments are to manage effects of this dysfunction through the use of medication like antidepressants. Now, these things are, we said, chronic and irreversible. Most of them are chronic and non-reversible or irreversible. So in such cases, it's very hard to stop the disease or bring back to the normal level. But what we can do, we can control or we can decline the progression of the disease. These things get worse over time. Right. Then we have vascular neurocognitive disorder. That's a very simple one. When the blood supply of the brain, or when the blood supply to a particular part of the brain is stopped or disturbed, what happens? That of course that affects the conscious brain function, so the normal brain function. The DSM includes this as a replacement for condition previously identified as vascular dementia. Now, before here, the frontotemporal neurocognitive disorder, now we call that in that name, but before it was known as frontotemporal dementia. Just like that, vascular neurocognitive disorder, now we call that in that name now. Before it was known as vascular dementia. So if you read some book and if the book says vascular dementia, just remember that's the same thing. DSM included that as vascular neurocognitive disorder. Now, so basically what happens in vascular dementia or vascular neurocognitive disorder, when blood supply gets obstructed, that part gets damaged, just like myocardial infarction, the mechanism. The term vascular in vascular this disorder refers to the body system of blood vessels known medically as the vascular system or circulatory system. Again the disorder name because impairment originate from some sort of reduction or blockage in the supply of blood here that normally passes through blood vessels. Causes for this condition are mainly the number one cause, a stroke. Yes, for heart it's like ischemia or myocardial infarction. For brain we know that's a stroke, a condition that occurs when brain artery either gets blocked or springs a leak of blood. Ongoing health problems that either decrease blood vessels general health or produce abnormal narrowing in blood vessels interior diameter. Conditions that can trigger these damage in blood vessels changes include atherosclerosis. Now, what are these? These are the conditions that can damage blood vessels. Atherosclerosis or heart arteries due to atherosclerosis, or hypertension, the high blood pressure, diabetes, and effects of normal aging, that means latest being senile or advanced age. Treatment for vascular dementia that's incurable and that shortens the life of affected individuals. However, doctors can potentially slow the disorder's progression. Yes, just like the disorder that we discussed earlier as well, slowing the progression or even stop its effect from growing worse over time, treated with the help of certain medications originally developed to treat Alzheimer's disease. Examples examples of this drug class, collectively known as cholinesterase inhibitors, which we discussed earlier as well, which will stop the progression. Yes, cholinesterase inhibitors and single drug called memantine. Then the next disorder, maybe you all are feeling bored now, but just pay attention. We are the last part of the presentation, right? There's one more disease and we are done with the PPT. Neurocognitive disorder due to traumatic brain injury. There's nothing much to discuss, from the name itself. Mental health condition that sometimes arises in long-term outcome of physical injury that results in brain damage. Now, let's say there's a brain damage due to an RTR or traffic accident. Now, what happens? Yes, the functions of the affected part of the brain will be impaired. Simple as that. Some people affected by neurocognitive disorder due to traumatic brain injury experience symptoms that are severe enough to degrade their ability to lead independent lives. Like we have seen patients who are getting brain damage and they will be paralyzed sometimes or bedridden sometimes. So that's there. Others experience mild symptoms and retain most of their day-to-day mental function. After RTA or such a traumatic brain injury, most of the time people might be confused, and later on they will return to their normal life. So if the damage is permanent, that can cause neurocognitive disorder due to traumatic brain injury. That comes both major and in mild forms. People with the major form of the disorder have symptoms that are general public commonly refers to dementia, including memory problems, declining ability to think logically, and declining ability to make decisions or control behavior. People with mild neurocognitive disorder due to traumatic brain injury don't have dementia-like symptoms. Instead, they have less dramatic changes in their mental function. So, in major, there are mainly two parts or two forms, major and mild. In case of major, they have symptoms like dementia, memory problem, logical problems with logical thinking, and declining ability to make decisions or to control behavior. In mild cases, they have less dramatic changes. So difference between mild and major neurocognitive disorder. Yes, with mild, they have impairment in their conscious brain functions, prominent enough to produce testing results lower than those found unaffected by disorder, but not prominent enough to produce serious life disruption. They have little problems, but not serious problems which disturb their life. Okay. Individuals with major neurocognitive disorder, that's considerably lower than produced by individual with mild form, and have impairment, at least partially eliminate their ability to live successfully. Okay. Mild and major. In major cases, that's the damage is permanent, and that disturbs their lives partially, at least. In mild cases, they most of the time they might return back. Right. Then the last part, what is that? That is amnesia. That's a deficit of memory caused by damage in brain or disease. This may be caused by head trauma, traumatic events, use of heavy alcohol, or physical deficiencies. Now, what is this? It's a deficit memory caused. It's a deficit memory or a memory deficiency caused by damage in brain or disease. May be caused by head trauma, traumatic events, use of heavy alcohol, or physical deficiencies. Right. Now, you may yeah, that's it with the presentation. But you may be wondering what's the difference between amnesia is also kind of memory deficiency. So you might be wondering what is the difference between amnesia and dementia. So let's move on to that part. At here, I have shown you all. In dementia, aging is a risk factor. That's a chronic thing. Increase with aging, increase with age. Yes, and effect impairment of cognitive function sufficient to cause functional decline and severe impairment in memory, judgment, orientation, and cognition. Onset slow and gradual with uncertain beginning point. Right? Severity is very high. In most cases, it's irreversible. Right? Amnesia, what is that? That's kind of a short-term memory loss. The exact word, short-term memory loss. Right? Aging is not a risk factor. Here, aging is a risk factor. Can happen in any age. This increase with age. This can happen at any age. Sometimes we used to mock people, right? Whether you are having short-term memory loss. Yeah. So that accounts for amnesia. Can be reversible or irreversible. Most of the time that's reversible. And memory impairment and forgetfulness. Here loss of functions also. Here cause a functional decline and severe impairment in memory, judgment, orientation, cognition. This is memory impairment and forgetfulness. They forget things. Sudden onset of memory loss. Yes, short term, we say day-to-day life, short term memory loss. Yes, right. Delirium is also there. You can refer to these things as well. So that's it about today's presentation, and thank you very much for your time. We hope you all of you all to be very safe. Right. Thank you.